Good afternoon, everybody. This presentation is on an overview of different aspects of clinical trials. Actually, it's like an introduction to trials because tomorrow we will have very detailed sessions on design of randomized clinical trial, registry-based studies, and observational studies. But here we will talk about some practical issues. So the first point is what is the research question if we want to start a new project and so on. So how to find the research question? There are, different ways to try to understand what deserves to be investigated in our daily research activity. The first one is to try to understand if in the long-established practice there is any misconception, and so if what is currently done could be done better. Another very important point, a very good research question could rise whether there are conflicting views on very specific topics, and so some investigation could be needed to solve the issue. And a very hot topic is always to try to understand if there are geographical variations for, for example, cardiovascular diseases, outcomes, and so on in specific populations. Once we get an interesting idea, it's very important to try to start to challenge the idea, just to have feeling if this is a good or a bad idea to be tested in our research. So first of all, we have to check if we have enough motivation to run a specific research project. Then we have to try to figure out if this is important for patients. Having patient-oriented research is always extremely important. It doesn't matter in which kind of topic we are going to perform our investigation, but having some clinical relevance makes the difference. Sometimes we have very good ideas, but maybe somebody else had the same idea. So it's always very good to go to check and, for example, screen PubMed and so on. But it's also true that sometimes some idea looks very, very, very simple, and since they look so simple, nobody has investigated them. Then we have to figure out if it's feasible to address the research question we want to explore. And for feasibility, we mean something like we have enough personnel, enough money, we have competencies to do what we are planning to do. And if, of course, it's ethically sound. And that's what I was referring to for feasibility. We mean also the availability of resources, financial, technical, patient, staff, expertise. For example, sometimes we work in a tertiary hospital and we just cannot find the patients we need for our research because we have very selected patients and maybe we need a different type of patients. So at the end, maybe we discharge 9 of 10 ideas we got, so there is a great selection. So another important question is what may help you to find out whether your idea is worth following it further. First of all, daily clinical practice. Checking daily clinical practice, we realize if the idea we want to test is an important one because we realize that we need something more when we go to treat our patients. Another point is always important to have discussions. So discussion with senior researchers may help. Of course, checking literature because this may help us to understand first if our idea has already been tested, and it can even help us to test what we want. For example, we can get from current literature suggestions regarding methods and so on. And of course, check trial and trial registries to see what is currently ongoing. Maybe we have a very good idea, and then we can find out on a trial registry that the trial is already ongoing. Another very important point is that we can actually find major gaps in evidence in the guidelines. Indeed, guidelines report what physicians should do in their clinical practice, but they also identify the problems that have not been solved yet. So if there are some gaps in the current knowledge, and we can go and try to fix these gaps. So very important to read guidelines regarding these points. Then it's possible to end up with irrelevant results. When does it happen? First of all, when we have like fishing expeditions. For example, we have like a big registry, huge data set with 100,000 patients, and we just check for association between all the variables included in the registry without having a clear research question. This is a fishing expedition, and in most of the cases, what we will find is just irrelevant. And of course, a question that is easy to answer, but is not of interest for anymore. This is also important. So how to translate our idea into a research question? First of all, we need to specify the hypothesis, and then we try to, so first of all, define the main idea, and then to specify the aims and the sub-aims. So first, a broad idea, and then we try to think about details. So for example, if we have an idea which is green apples keep the doctor away, very scientific. The research question may be, do green apples prevent myocardial infarction? So there is already a little bit more detail in the research question as compared with the overall idea we had. And then we can specify the aim that may be a little bit even more specific, whether a green apple per day prevents myocardial infarction in patients with high cardiovascular risk. And then try to be even more specific and provide some sub-aims, whether green apples lower the risk of myocardial infarction in patients with hypertension and hypercholesterolemia. For example, here we are providing more details regarding the population we want to enroll, whether the apple intake must be for 1 month or 12 months, or whether green apples prevent STEMI but not end STEMI. So in the sub-aims, we are even more and more specific. So how can we answer the research question? Here, important points are to define study design, study population, exposure, endpoint, and follow-up. This will be mainly the focus of the discussion tomorrow, when we will focus on randomized controlled trials and observational studies, meta-analysis, and registry-based studies. But now we provide some insights. First of all, we have to specify that when we talk about interventional studies, the gold standard is randomized controlled trial. A very important point in interventional studies is to define the control group. For example, should the control group receive the standard therapy or the placebo? That's a very important question. And another key word is randomization, because it ensures that the treatments group are only different with regard to the intervention. This is very important because it rules out the presence of confounders that are one of the major issues when we rather discuss registry-based studies and observational studies. So tomorrow we will talk about different types of randomization, and we will also talk about observational studies and registry. So we will try to understand how important it is to try to face the problem of confounders, and so we will discuss adjustments, propensity score matching, and so on. So in observational studies, we test the association of a risk factor with an outcome. There are different types of observational study. We can get core study. We start with a cohort and wait for events to occur. Case control studies in which we compare individuals with the disease to individuals who do not have the disease. Cross-sectional studies where we investigate prevalence of disease and risk factor determined at the same time, so there is no mention to the follow-up. Then there are descriptive aims and descriptive studies where we investigate, for example, the prevalence of disease or time trends in disease or use of treatments and so on. And of course, this was what I was talking about, the difference between observational studies and intervention and randomized controlled trials is the presence of bias and confounding. So how do we define bias? Bias is a systematic error that results in a conclusion which is not true. There are different types of biases. The most important are the selection bias, where patients or study procedures are not comparable. Tomorrow we will provide more examples regarding that. And information bias, where the information is not comparable due to the reporting by participant or due to the observing by the researcher. We define confounding all the factors that affect the effect of the exposure on the outcome. There could be a positive confounding. That means that the effect seems stronger due to the presence of confounder, or negative confounding, where the effect seems weaker due to the presence of a confounder. So how can a study design avoid biases? For example, in interventional studies, we avoid selection bias by randomizations, where groups are comparable, fostering adherence to protocol, and using an intention to treat scheme. Tomorrow we'll talk about this. Whereas in observational studies, we face selection bias, for example, by performing matching of patients. How do we face information bias in interventional studies? We perform double blinding, whereas in observational studies, in order not to have an information bias, participants should be unaware of study aim, and researchers should classify endpoint unaware of exposure of individuals. So let's see, for example, an observational study, and let's try to understand how they work. This was an observational study. The rationale of the study was the comparative safety of dabigatran versus warfarin for treatment of non-valvular atrial fibrillation general practice setting, which has not been established yet. So because of that, the investigators wanted to assess this point. As methods, the authors performed a propensity score matched study using the Medicare population and went to check patients who had started dabigatran or warfarin between 2010 and 2012. So there were around 140,000 patients and around 3,000 events. So here we can see the first difference with trial. So here we have a much larger population as compared with the trial. Of course, this is not a trial. So here the major problem will be to understand if the results can be explained by a confounder or there is a real effect. So this is the problem that rises when we want to perform a study like this. But the authors try to face the problem of confounders using a propensity score matching. So as you can see, they matched patients received dabigatran with those receiving warfarin. They got two cores consisting of around 70,000 patients. And actually, they report the baseline characteristics. And as you can see, there were no differences at all for baseline characteristics. The standardized mean differences means that as small it means that there are no difference between the two groups. So it's good to have like 0. For example, there are no differences at all for a specific variable in the two groups. So a lot of baseline characteristic tested, and still there were no differences between the study groups. So here we could actually assume that the two populations were completely comparable, and so we test the association between treatment and outcome, and we can discuss about effect of a treatment. This is not true, because there could be still confounding. The reason for that is that we perform a propensity score matching, meaning that we decided which variables to be considered to run the propensity score matching. When we have randomization, we adjust for known and unknown confounders. But when we run a propensity score matching or adjustment with multivariable models, we decide for which variables we want to adjust. So we adjust for known confounders, but not for unknown confounders. Unknown confounders could be reasonable confounders, but not reported in the data set, for example. Those are unmeasured confounders. Tomorrow we will talk a lot about this. So when we run a propensity score matching study, patients are matched only for known variables. It's very important to keep this in mind. So let's check together a very important study where the investigators investigated the association between number of storks and delivery of babies. So, and they found out that there was a strong association between the number of storks and the number of newborn. So what should we think here? We should think that, of course, the storks deliver babies. But the conclusion may not be that one, because this is what we should think reading this paper, but there may be a confounder in this association. The confounder may be the land area. Of course, there are more storks in larger towns because they have more space to live in. And if the land area is larger, there will live more people there, and so there will be more newborns. So, of course, there is an important confounder in this association, and this is land area. So this is very useful to define a confounder. A confounder is a variable that affects both the exposure and the outcome. Another example is typical study. Does the coffee increase or reduce cardiovascular mortality? It looks like yes, but then we think a little bit more about this issue, and we discovered that a lot of people drinking coffee also smokes, and smoking is one of the major determinants for cardiovascular mortality. So always important in observational studies to check for confounders, and in observational studies we can never talk about effect. We can just talk about an association. So if we read a paper reporting an observational study and they report that they found an effect, this is wrong. It's a mistake. So it's needed to use the right terms, and the term is association. So since it's very important to be able to talk about effects, and that's what we do in clinical trials, we need to find out how to completely remove the influence of confounders in our studies. And the only way to do that is to use the randomization. When we randomize patients, we adjust for known and unknown confounders. So at that point, we can talk about effects of a treatment. And other very important points when we plan to run a trial is to define the study population. That's extremely important, and right now there is a lot of talking about this. First of all, we need to define the sample size, and then we have to assess external validity. Sample size calculation is needed in order to have a powered analysis, meaning that our analysis, our population is enough large to be able to show if the treatment is has an effect on outcome. And there are some methods and techniques in order to calculate sample size, and tomorrow we will do this together, like an hands-on activity. And then right now there is a lot of discussion regarding the use of very strict or very broad selection criteria for trials. There are pros and cons for both approaches. If we use very strict inclusion criteria, we have a very well-defined study population that makes the effect more predictable. So we have a very strong internal validity. It's safer due to the exclusion of high-risk patients. For example, in a lot of cardiovascular trials, they exclude patients with severe renal disease, for example, because these patients are at very high risk, and usually a lot of treatments are excreted by the kidneys. And then if we use strict inclusion-exclusion criteria, it's more difficult to recruit patients, of course. The cost increases because we will have a lot of patients screened, but very few will be included. And the time of recruitment, the risk for failure of this study will be high. So there is a limitation regarding the use of very strict inclusion-exclusion criteria. What about using broad inclusion-exclusion criteria? Of course, we increase external validity. What does it mean? That if we have a treatment tested in a very heterogeneous population and it works, it means that a lot of different people could benefit of this treatment. But if we have a very selected population and we see that this treatment has an effect on outcome in that very small population, the treatment could work there, but not somewhere else. So using broad criteria increases external validity, but of course we have a less defined study population, and so the internal validity is reduced. And of course, using broader inclusion and exclusion criteria facilitates the recruitment of patients, and this means that the trial will be also cheaper. This is a list, for example, of inclusion-exclusion criteria of an anticoagulation trial. You can see that the list is extremely long. This is just to show you that the population is extremely selected in trials, and this raises important concerns regarding external validity in some occasions. For example, let's see the Jupiter trial. Between 2003 and 2006, around 90,000 people were screened for enrollment. But after applying inclusion-exclusion criteria, they just got the 20% randomized to the study. So here the question is, when we get a positive result from such a trial, can we really apply to the overall population if we select so much the population in the trial? So this is, of course, an issue, and this is the issue regarding external validity of trials. We will talk about this tomorrow. Then it's a very important, when we start an interventional trial, for example, to define very well the intervention, for example, the dose and the duration of the treatment. If we have a biological measurement, this should be standardized. And then if we have as an outcome a questionnaire, for example, this should be really standardized. Otherwise, we may have like different outcomes due to the different way of collecting the outcome per se. Very important, the choice of clinical endpoints. Of course, the best clinical endpoint is always mortality. But sometimes it's not possible because maybe it takes so long time to occur that the trial should be run for 20 years or something like that. So sometimes it's not possible to have such hard outcomes. So we may use surrogate endpoints, but this allowed to test, like, for example, a treatment in a smaller population, but then the point is the treatment reduced the surrogate endpoint, but is the surrogate point that's associated with the outcome? So it's very important to use surrogate endpoints that are well known to be associated with hard outcomes. And then the choice of the follow-up, how to do it, for example, by visits or telephone contact or using like mortality registries and so on. And then the choice of the length of the follow-up is very important. If it's longer, there may be more endpoints, and it could be like an endpoint-driven follow-up. If it's shorter, we may rather evaluate a closer association with an initial intervention. We will see this tomorrow. And then, very important, very practical issues. What do I need to perform the clinical study? First of all, have a study protocol. It's like a schedule for the study. And it's always important to define before starting, like the title and the authors of the study, not to have problem later. Define very clearly the rationale for the study, specify the research question, aims and sub-aims, define study design, location and study population with exclusion and inclusion criteria, define the exposure and the outcome, then define a priori the statistical analysis that will be performed, consider ethical issues, define how the data will be collected, have a study flow. Tomorrow we will see that there are different study flows for different types of trial, and then define logistics and resources. Data acquisition is very important. The aim is to have a complete, correct, and standardized recording of key data. Which information should be collected? First of all, exposure, confounder, and endpoints. The sources could be different. For example, data could be already collected in a registry. They could be like ICD codes from electronic health records and so on, or could be collected by questionnaires, or it could be like biometric measurements and so on. Once data are collected, they have to be transferred into a database, of course. Some general statistical considerations, then tomorrow we will have like hands-on on statistics. What is the gold standards? Of course, for trials is the consort statements. We will talk about this tomorrow together with the randomized controlled trials. It's always important to check instruction for authors of journals. Then we have to report regarding statistic a description of the population, so like descriptive statistics. Then to use analysis to assess the association, for example, between an exposure and an outcome, and provide, for example, univariate and multivariate analysis. And if we are dealing with outcomes like mortality, myocardial infarction, and so on, to use like time-dependent or independent analysis. We will see this tomorrow. And then always consider whether external validation is needed, and if a non-treatment rather than an intention to treat protocol should be used in trials for analysis. Tomorrow we will talk again about this. Very important to, before starting, to be sure to have resources, so to have enough patients. If we don't have in a single center enough patients, a multi-center study should be considered. That's what is done, for example, for most of the randomized controlled trial. If we have enough personnel with dedicated time, enough financial resources, and financial resources should be available for the whole study duration. Both observational, like registry-based and so on, meta-analysis, and clinical trials can be registered online on specific registries. For example, clinicaltrial.gov is one of those. We should always try to publish everything, so in order to avoid, of course, a publication bias. So even though we have like a study with neutral or negative results, we should try to publish it. That's very important. Tomorrow we will talk about the assessment of publication bias, for example, in meta-analysis. And the registration, for example, of studies in these large data sets of trials avoids, for example, to conduct the same study twice, so patients are not exposed to, for example, a potential dangerous treatment twice. Always have a predefined analysis in order to prevent phishing experiments. So, as a conclusion, before we start the adventure of a clinical trial, we should have an idea, a very clear idea, and then we should challenge our idea to be sure that it's a good idea. We have to check for resources, have a good expertise, and have a study protocol. And this is just an introduction. Tomorrow we will talk a lot about each of all the stuff reported in this presentation. In any case, thank you very much for your attention. If you have any question, please ask.